Today, you are connected to over 800 colleagues from across the United States. 49 states are represented, and we have participants from Canada. This is actually the first of 2 complimentary webinars NHPCO is offering today on trauma-informed care. We Honor Veterans, a NHPCO program in collaboration with the Department of Veterans Affairs, will discuss veteran-focused trauma-informed care this afternoon. If you missed that webinar, you can view the recording, which will be posted to the NHPCO website. We know your time is very precious, especially now as you face the many challenges brought about by the COVID-19 public health crisis. Thank you for spending time with us today. As the leading organization representing person and family-centered interdisciplinary care, the purpose of today's webinar is to give practical guidance based on where we are right now and ongoing inspiration to hospice and palliative care providers so they can do the utmost to care for patients and families. We are adding COVID-19 resources to our website daily. As of today, NHPCO has created 34 new resources, issued about 60 COVID daily updates, submitted 10 letters to Congress and the administration, hosted 9 COVID webinars, and our work continues. Today, we will focus on trauma-informed care. NHPCO is committed to ensuring hospice and palliative care professionals and volunteers are knowledgeable about trauma-informed end-of-life care and that they practice in a manner that actively resists re-traumatization or traumatization of those receiving and providing care. Today, you will hear from members of NHPCO's Trauma-Informed End-of-Life Care Work Group on how they are supporting patients and staff. They will share guidance for naming and framing trauma-informed care, managing grief, and incorporating self-care to help make your life better so that you can then care for others. The work group has added resources for easing stress and trauma in a time of COVID-19 to the NHPCO website. This is truly a virtual event. No 2 faculty are in the same location. NHPCO President and CEO Ido Banik will get us started, and then we will hear from 3 members of the Trauma-Informed End-of-Life Care Work Group. Reverend Dr. Carla Cheatham has extensive hospice and counseling experience. She also chairs the NHPCO Ethics Advisory Council and has led the My NHPCO Spiritual Caregiver Community. Dr. Barbara Ganzel is the director of the Gerontology Institute and an associate professor at Ithaca College in New York. She has over 20 years experience studying psychological trauma and its impact on brain, body, and behavior. Diane Snyder-Cowan is director of Western Reserve Grief Services at Hospice of the Western Reserve. She oversees on-site and community bereavement programs, as well as all the nonprofit agencies' expressive therapy programs. Diane serves as the leader of the My NHPCO Bereavement Professionals community. We are so very grateful to our faculty for sharing their expertise and insights. Please note that the faculty and planners for today's webinar have no relevant financial relationships with commercial interests to disclose. To learn more about our faculty, please visit the NHPCO website. For participants interested in earning CE/CME for this webinar, I will share more information as we conclude today. Let's review just a few logistics before we begin. Your audio line has been muted to reduce background noise. You will not be able to unmute your line. However, if you need assistance, please use the Q&A feature in the navigation bar at the bottom of your screen. Please do not use the chat feature. We're reserving that tool for our faculty communications to ensure a successful webinar. Many questions were already submitted for today's webinar, and additional questions may be submitted using the Q&A feature. Our faculty will address as many questions as possible. A recording of today's presentation and a PDF of the slides will be posted to the COVID-19 section of the NHPCO website. And now, I'm delighted to introduce NHPCO President and CEO Ido Banik. Welcome, Ido. I will turn things over to you now.
Carrie, thank you so much for having me on. Thank you also for Barbara and Carla and Diane for your leadership and for the leadership of the entire counsel and all of the folks who give so selfishly of themselves to help educate others. We're at a time of incredible change, incredible, arguably trauma, where people are struggling to get through with the day-to-day as we deal with COVID-19. We deal with the longstanding reality of the inequities in our healthcare system and some of the racial justice issues that are very real. And I want to say, no matter what trauma you're feeling, it's legitimate. I'm not a professional here, but I want to emphasize that people come to their jobs, their lives, and end of life with all sorts of trauma. And our job collectively is to be mindful of that and do it justice and not exacerbate it. And I go back to the origin story, one of the origin stories of hospice itself, which was in 1948, David Tasma was his name, was introduced to Dame Saunders. And David was a Holocaust survivor, recent immigrant from Europe to London. And what Dame Saunders saw, Dame Cicely Saunders, founder of the modern hospice movement, but at the time was early in her career, what she saw was that someone who was dying of cancer had a lot of other things that were obviously on his mind. And this resonates with me, first of all, as an origin story of hospice and the reality that people are struggling with a lot of things, not all of them physical, at the end of life and really throughout it. My grandfather could have been David Tasma. He was a Holocaust survivor in 1948. He was pretty much the same age as David Tasma. And I saw him struggle with that trauma for the rest of his life. So it's very real for me, and understand we're all living through various traumas. And I'm so glad that we have these incredible faculty to take us through what we're dealing with and make sure that we're better trained and better prepared to help each other and to help the folks out there who require assistance. So again, with much gratitude, I turn it over to the faculty, and thank you so much again for giving of yourselves. Carla Cheatham is one of the best in the business, and I'm happy to hand it over to her. Thank you.
Thank you, Ido and Carrie. It's a pleasure to be with all of you. We're so grateful for all of your interest and wanting to be a part of this today. As Ido and Carrie have both mentioned, we know that we are all facing a tremendous reality, unlike anything that most of us have seen in our lifetime. We know that the work that we do is already challenging. We talk most often about issues of burnout and compassion fatigue that we as workers in the healthcare industry can face, the work overload, feeling a lack of community control, fairness, lack of reward, of values conflicts between the ways that we like to work and the ways that the agencies that we work for may be engaging with the work. We know that we also face a tremendous amount of compassion fatigue, where the caring energy that we are putting out, it can sometimes exceed the amount of caring energy that we're taking in for ourselves. That's normally what we talk about, but we are not in normal times. We are now in a time when we are facing a new reality. And this new reality looks like this. We are facing even more moral distress than we ordinarily might. Moral distress being we know what to do, but somehow we're constrained from being able to do it. We ordinarily think of this when a patient or a family is not willing, isn't interested, or doesn't feel comfortable going along with our treatment recommendations, for instance. We're somehow constrained from doing the work that we know to do. If we could just do this, everything would be fine. We're facing that moral distress in a different way, because suddenly, whereas the patient's needs are normally primary, in the time of a crisis like this, suddenly we have to put the global needs above the needs of the many, above the need of the one. And so we're making decisions unlike any that we've ever had to make, leaving people often even to die alone, or not being able to visit people, both professionally and even personally, if we have loved ones that are in skilled nursing facilities, for instance. All of this that we're facing is not just professional, but it's also personal. We want to name that too. We are facing an increase in moral injury, where we witness or engage in behavior that goes against the normal norms, the normal morals of what we know to do. We know how to be good nurses, chaplains, social workers, bereavement coordinators, etc. in this industry. We know what to do, but we're in positions where we're making decisions that we thought we would never, ever, ever have to make. And it's heart-wrenching. We are also facing our own trauma. We're not only experiencing vicarious and secondary trauma of witnessing the trauma that others, the patients and families for whom we care, are experiencing going through end of life, but also end of life and palliative care at this precarious time where all the rules have changed. But we also have our own individual trauma from, again, the personal of being worried about our families, our loved ones. Are we taking something home to the people that we care about? Are we placing ourselves at risk with our employment if we have things that we're not comfortable with doing? The threat or the perceived threat or the risks of something that can cause us harm physically, emotionally, etc., is enough to cause trauma for anyone. So just during this time period, if you are feeling traumatized, you ain't broken, you ain't weak, there's nothing wrong with you. You're a human being that is quite normal, but we're going through an abnormal situation. And our responses, the fatigue, the stress, the anxiety, it's very normal. So if you're feeling that way, you're not alone. Next, please. So the stressors that we're facing can be enough to leave us wanting to hide underneath the covers or run screaming for the hills, or as I've often said, it's enough to make us want to take a silly straw and stick it right into the box of chillable red Franzia wine and hold it to us like a grown-up juice box and just drink the wine straight from the box. So however it is that you're struggling, whatever it is that you're facing, not just professionally, but also personally, we want to know that we see you, we hear you, we're with you, and you're not alone in that. There's nothing wrong with you. The stressors that we're facing are enough to be hard for any of us. So as we talk today, we want to talk not just about caring for patients and families in the midst of their own trauma and how to show up in a trauma-informed way for them, but how to show up in a trauma-informed way for ourselves first, so that we can show up then and be aware of the trauma of our colleagues or those that we may be supervising or leading, and then also show up well for the patients and families we serve. Next, please. So as we go into this time, here's an invitation. Please hear these words from Mickey Scott Bay Jones, who says that we want to have an invitation into brave space. So together today, we will create brave space, because there is no such thing as safe space. We exist in the real world. We all carry scars and have all caused wounds. In this space, we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect, and that's okay. This space will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will work on it side by side. Barbara?
I am Barbara Ganzel, and I am, that didn't work, working on sharing my slides with you. Is that working, folks? Carrie, can you hear me?
I can hear you and see you. I do see your notes.
Oh, shoot. Well, we're gonna have to switch that. How's that?
Looks great.
Okay, well, let me get the chat box out of here. Okay, well, it is always a pleasure to follow Carla. Carla is an inspirational speaker. The concept of a brave space resonates with me. We need this. We need to create brave spaces, safe spaces, or safer spaces for ourselves, our patients, our families, and our organizations. In my work, I try to translate ideas like this into programs. Into programs that can be implemented in end-of-life care. in my short time with you today, I want to give you some highlights of our work on trauma-informed end-of-life care for patients and introduce some new approaches to trauma-informed care and stress resilience for staff. For more material on trauma-informed care, please see a talk by Leanna Anderson, Scott Jansen, and me on the NHPCO online learning page under trauma-informed end-of-life care. The goal of trauma-informed care is, as I said, to create these brave spaces in a real world where people are dying all the time. The impact of a trauma-informed care or organization is through its ability to realize the prevalence and impact of trauma, to understand how to assess and treat the signs and symptoms of trauma, to integrate this information into its policies and practices to prevent client and staff re-traumatization, and to promote client and staff empowerment in a culturally sensitive framework. Let's touch first, there we go, on why this is relevant to end-of-life care. Let's talk about the prevalence of psychological trauma in the general population, which provides the first estimate for what you can expect to see in hospice and palliative care. A study of adults in the United States between the ages of 18 and 99 found that more than 80% of people surveyed had experienced at least one trauma level event in lifetime. This was using the most conservative, the narrowest definition of trauma, psychological trauma, so that if anything, it's underreporting. This was a nationally representative survey, an epidemiological survey, so we can estimate from it that more than 80% of the population of the United States has experienced a trauma level event, including your patients and residents in long-term care and your staff. These numbers have been replicated elsewhere in the research literature, so they're pretty real. This is important to patient care because symptoms of stress injury from trauma are associated with increases in perceived pain, increases in anxiety, depression, distrust, anger, and this can include distrust of caregivers and care providers. It can also be avoidance, can also include avoidance of trauma reminders, which can mean avoidance of medical settings and providers when the trauma is from medical intervention. And decreases in patient staff collaboration and overall decreases in patient care. In hospice and palliative care, we typically see patients who are older and sicker. Older patients are more likely to have experienced the death of loved ones, which is often endorsed as a worse trauma in lifetime, even from people who have experienced combat trauma or rape. And older patients are more likely to be experiencing age-related reactivation of trauma injury, of prior traumas that may have been dormant for decades. This is a phenomenon called later adulthood trauma re-experiencing, or later, LATR. And I invite you to look it up because it's important and it's interesting for our work. People who are older and sicker are more likely to be experiencing symptoms of this trauma re-experiencing on top of medical interventions that can intensify dramatically but do less and less good. Intensive medical intervention can be a trauma in itself. And all of this can peak at the end of life, making this a locus of medical trauma, reactivated trauma, and overall stress injury in patients. Here's my representation of how it must feel to experience all of these effects at once. Again, for more detail about trauma-informed patient care, please see the NHPCO online course on trauma-informed end-of-life care. Okay, let's get to here now. Trauma-informed care applies to staff as well as patients. There is the goal of preventing inpatient and staff re-traumatization, and it goes without saying, but I do say it. Here we want, in this time of COVID-19, to include preventing of new psychological stress injuries or traumas as well. Here's my representation of hospice how long-term and hospice and care staff during the COVID-19 pandemic. The absolute global weirdness of this situation is unprecedented, and so are the levels of stress that people are reporting. How do you keep yourself safe? How do you keep your patients and families safe? How do you keep your families at home safe? And what on earth is going to happen next in 2020? Staff self-care is embedded in trauma-informed care. As hospice and palliative care staff, you are on the front lines of the COVID-19 pandemic response. Frontline stress deserves and requires specialized training. The stress first aid model is a set of supportive actions designed to help you and your staff with self-care and coworker support. This program was developed for the U.S. Navy and Marine Corps to mitigate the negative impacts of stress in frontline troops. It has since been adapted for civilian fire, rescue, and law enforcement, and now here for the frontline healthcare workers in the COVID-19 pandemic. Stress first aid includes 7 actions that can help you identify and address the early signs of stress reactions in yourself and others in an ongoing way. The stress continuum model is a visual aid for assessing an individual's stress experience zones. Stress is experienced, zones of stress, and stress responses. It forms the foundation of stress first aid. Stress responses lie along a spectrum of severity and type, from transient and mild to chronic and debilitating. The continuum has 4 zones: ready, reacting, injured, and ill. In red, everybody reacts when faced with significantly stressful experiences. And people's reactions range from can range relatively rapidly from green to yellow to orange, maybe touching on red and go back again. Within this range of reactions to stress, a person can go from optimal functioning, feeling physically fit, calm, and motivated into what's called the yellow zone, where they're having more stress reactions. But the stress reactions are mild or transient, and they always go away. In the yellow zone, a person can feel more irritable and anxious, down, and a loss of motivation, loss of focus, have trouble sleeping, muscle tension, other physical changes, but these are transient reactions. They do not stay. Remember, the COVID-19 pandemic is an abnormal situation. A stress response is normal within an abnormal situation. So you're having a normal reaction to an abnormal situation. 100% of people react when faced with stressful situations. And stress reactions in the yellow zone are common. This is a normal part of developing competence and confidence in the face of life's challenges. Stress injuries in the orange zone and the red zone, stress injuries and stress illnesses result in more significant effects of stress on mind, brain, and behavior. If you enter the orange zone, it's usually caused by an accumulation of different types of stressor, or one pretty bad one. In the orange zone, you start to see more severe and lasting distress and impairment. The person doesn't feel like themselves, or they may have a loss of control of their stress reactions. They may feel panic or depression, rage, guilt, or blame. In this zone, it starts to feel like that stress is leaving a scar, and the person is at high risk for having trouble functioning and/or strong and persistent distress. What signifies a person being in the red zone is that their symptoms are very persistent or worsen over time. And they have, under these conditions, a person typically has enough symptoms to be diagnosed with a clinical disorder like depression, anxiety, post-traumatic stress disorder, or substance abuse. This model was designed to help people move themselves or their coworkers from the red and orange zones back to green and yellow. In many high-stress cultures, the norm has been to tough it out. In medicine, the norm has been to tough it out. And people may try to conceal their stress reactions, but it's usually not possible to keep these behaviors hidden for long from your family members, from your coworkers, and your friends. When a coworker recognizes that someone's in trouble, it is important to break that code of silence. Getting this individual connected with the next level of help as soon as possible may help prevent his or her reaction from moving into the red zone. If an individual stays in the red zone for any length of time, the goal is to help get them help, including treatment as soon as possible. And it's a fact of neurobiology. That's why this is so important, that naming a feeling or emotion helps reduce our automatic fight, flight, and freeze responses. And it helps bring the prefrontal cortex online to help us exert some cognitive control. So the idea is to name it, to claim it, reduce those fight, flight, or freeze reactions, and include and improve cognitive control. Given what we just talked about, where would you put yourself on the stress continuum today? As I said, there's power in naming it. Some people think they should always be in the green zone, but that isn't as good as you think. Healthy challenges take us out of green and into yellow and back again. That's how we grow. On the other hand, some people don't believe the green zone even exists. Either way, there's value in knowing where you stand on the stress continuum. So the first selection is green zone. The second selection for people on phones is yellow zone. Orange zone is 3 and red zone is 4. And we'll report the results of this poll at the end of this talk. So make your selection and submit, and I'll keep moving. Oh, look, so we have a lot of people. We have an automatic response. We have some folks in the green zone. We have a bunch of folks in yellow, some in orange, and some in red. And it is important to know this. Stress first aid model is based on research literature that says that people tend to do better in ongoing stressful circumstances when they have one or more of 5 essential elements to counteract adversity. Stress first aid maps onto these 5 elements. That's these elements here. And adds 2 more core actions, because in a long-term model it is a long-term model that's designed to help us support ourselves and our coworkers. The stress first aid model is initiated when a person experiences one or more stressful circumstances, which can occur either at work, so these are the first 2, the check and coordinate, which are the 2 that are added to these 5 to make it an ongoing activity. Stress first aid is initiated when a person is, when the check and coordinate actions happen and you see that there's a person experiencing stressful circumstances, either at work or at home. It's different from other models like critical incident and stress management because the stress first aid is not initiated unless the person is experiencing or showing stress reactions. It's also different because the stressors could occur at home and only be detected by fellow coworkers because of the changes they see in how a person looks or acts. Checking in with self or others has been added to the 5 essential elements because it involves observing, paying attention, and checking in on coworkers. This action should be ongoing and continuous, even before stressors and stress reactions happen. Coordinate has been added to the 5 essential elements as an acknowledgement that the stress first aid model is first aid, and therefore it should be care to bridge the gap to a higher level of care as needed. This action should also be continuous and involves always being aware of additional resources you may need to refer yourself or a coworker. Once stressors provoke a distress or loss of functioning, there are 5 core actions that can be considered. Cover maps onto helping a person feel safer. Calm involves calming the person down or staying calm through an extended difficult experience. This is stress symptom control management, whereas cover is about safety. Connect involves helping a person feel a greater sense of connections to others, which may be coworkers, mentors, or family members. This is important because when people go into the orange zone, they often isolate themselves from others and remove the possibility of social support. Making connections to others is very helpful to recovery from stress injuries of all kinds. Competence involves helping a person feel more capable in a number of different ways, including more capable of feeling their duty, of performing their duties at work, feeling more capable to handle their own stress reactions, or feeling better able to function and recover from stress. Confidence here maps onto being having more confidence in themselves, their work mission, or their leadership. It can also involve helping reduce guilt or anger, or helping people make meaning, or grappling with philosophical questions that arise as a result of stressors in their life. This diagram makes it seem like these actions are sequential, but in actuality, check and coordinate are continuous, and the others are only used as needed. So, like this, the stress first aid framework, and this will be my last big slide, is designed to be very flexible. And here's an example of how it can be used in coworker support. You check, you act and approach, and you decide what is most needed. Ideally, what you would do if had any stress first aid action is to pay attention and be aware of what's happening in a highly stressful moment or a person's ongoing circumstances, so you can see changes in how they behave. Then you would either act to mitigate them or approach the person and together decide what is most needed. These choices are usually based on what type of stress reactions they're having. So the options are calm, cover, competence, connect, and coordinate. And let's say for grief, you may want to implement actions to promote calm and connection. With anxiety, you may want actions for calm, connection, and competence. For guilt and shame, you might want to go with calm, confidence, and connection, and competence. Sleep problems, calm, confidence, and because they can be so difficult, you might want to help them coordinate with a higher level of care. Isolation, confidence, and connection may be the best tools to mobilize. And for someone with a severe inability to function, coordination to a higher level of care may be the thing that is most needed. The model allows you to be both practical and creative depending on many factors, and they should look different in every exchange that you have with a coworker. It is not one size fits all. This is also a framework that validates what you are already doing to help coworkers doing to help coworkers feel safer, calmer, and more connected, competent, and confident. Can remind you to consider these elements when either yourself or a coworker is exhibiting moderate to severe stress reactions. For more information on how to implement stress first aid in your organization, please look for the Stress First Aid Toolkit online in the NHPCO web resources. For more on how to do it, examples, and stress first aid for groups. I also want to do a shout out, to Carla and, Patricia Watson, who has been my contact at the National Center for PTSD. She has been she has been instrumental in developing the stress first aid model, and she's been extraordinarily helpful for adapting it to these purposes. Here is my contact information. If you have questions, please do feel free to get in touch.
Okay, thanks, Barb. It looks like I'm going to be taking over now, but I'm going to ask, there we go, grief and trauma. So I'm Diane Snyder-Cowan from Hospice of the Western Reserve in Cleveland, Ohio, and I'm going to talk a little bit about trauma-informed care and grief and trauma, grief reactions, sometimes mimic depression, sometimes mimic stress reactions. Grief can look like trauma could look like grief. Trauma reactions are similar to grief reactions, and it gets really, really complex, even as I just say those words. So next slide, please. Thank you. So right now we are in the midst of a pandemic, right? And we are experiencing the loss of our assumptive world. In fact, our assumptive world has been shattered, and this is traumatic. All of us know what grief and loss are like now. We're all experiencing grief and loss. Our assumptive world is all the things we take for granted. Getting coffee with friends in the morning, going to meetings, going to work, seeing patients, going to restaurants. It's for our kids, it was going to school or going to graduation. Will they go to camp? Will they go to college in the fall? So everything has been uprooted, it's been shattered. And we have a loss of safety and predictability, and that's really hard on us. And our beliefs help us navigate the world. And when they've been disrupted like that, it causes fear and anxiety and stress, and we can't feel safe in the world. We can't protect our loved ones. You know, we feel like we are able to protect our loved ones, but in this time we can't. So we have the loss of the assumptive world with COVID-19, and we have the pandemic and the trauma of the racial injustice and the protests that are happening. So you can have your person in your life that you're caring for, or you're working with these patients that they have hospice, that they're end of life, they're experiencing trauma from just having maybe a medical diagnosis or being old, or they might have a trauma symptom triggered from earlier in life, or they're having COVID-19 as their trauma, or they're having news in the riots as another trigger for their trauma, or maybe they experienced a trauma in their lifetime. So it's all of this happening at the same time. Next slide, please. So what happens is our grief gets really messy and complex. And grief is a normal, necessary, natural reaction to any loss. That's any loss, including death. It's unique. There's no fingerprint. I mean, it's as unique as a fingerprint. It's a total body experience. It's our heart and our head and our physicality and our spirituality and how we process things. There's no right or wrong or good or bad. There's no stages. It's not linear. It's more like a tsunami or a roller coaster. And so when I speak of compounded grief, we have all these different things that are happening right now that compound the grief and make it complex. So we have the variables from the pandemic. We have the variables from trauma that just comes with getting old and being a hospice patient. We have, in a different chat, we talked about how COVID is impacting anticipatory grief and post-grief. So perhaps the person couldn't see their loved one before they died. Perhaps they were dropped off at the hospital, or they were in a nursing facility. So people have grief around that, and then hospice staff are filling in as that person, or maybe the hospice staff aren't allowed into a nursing facility and they're having grief around that. And then you have, we have a lot of people say that they feel robbed after the death, that they couldn't go to the funeral, and they couldn't have calling hours or sit Shiva. So there's all these feelings that compound the grief. And then we have secondary losses, and these are very important as well, and disenfranchised grief. So disenfranchised grief is when your grief is not openly acknowledged or publicly mourned, and it includes all different kinds of things people are feeling. And you might have someone saying, well, my person didn't have COVID, so I guess I really shouldn't feel so bad. But yes, your person died in this COVID era, and you can feel as bad as you feel. We don't want to take that away. We don't want to disenfranchise anyone's grief. And there's all these other things people are grieving with these secondary losses: financial losses, job losses, the loss of caregiving. We hear so many stories about, I couldn't go visit my person in the nursing home, and that individual wrapped their life around going and giving their person lunch every day in the nursing home. So that happens as well. And then there's ambiguous grief, and people don't even know what they're grieving, which is really hard. They might feel threatened, which is part of ambiguous grief. And this is based on the work of Pauline Boss, by the way. But they feel threatened and they don't know what they're grieving. Or ambiguous grief also includes when you are grieving someone who's physically present but psychologically absent. So perhaps you're with someone, but they're not there because of cognitive impairment or brain failure or drug use or what have you. And then maybe you have someone who's psychologically present who's physically absent. For example, if they're incarcerated or hospitalized, or you don't know where they are, but they're present inside you, and you can feel their presence. That would be ambiguous grief. People just not knowing what they're grieving, but knowing that they're grieving something. And then you have lots of people are delaying their grief, but guess what? You can't really delay your grief because it's going to be inside. And we talked about how trauma impacts people and lives within the body. And healthcare workers, hospice workers, I've talked to so many people who are not thinking about their grief and their feelings right now because they need to put one foot in front of the other. They need to get their job done, and this is how they're managing. They're delaying their grief. Or families who are saying, well, I'm going to think about this later. I can't think about it now. It's too much. Or I'm going to have the funeral later. But there are things that they can do in the meantime so that they don't delay their grief, because their grief will catch up with them. And then we have cumulative grief and multiple losses. And this is really, we hear these sad stories where you see a family member that had multiple family members die. And that is such a sad story. And then we have healthcare workers who've had so many deaths in their hospital system or in their hospice, and they're grieving as well. This adds up. And this is what contributes to the compassion fatigue. And how are we filling our souls so that we continue to do this work? If you can go to the next slide, please. I'm talking fast because I want to cover all these things. We need to talk about what could be a trigger for trauma and for trauma symptoms, whether it's trauma based on your whole life's worth of traumas that you've encountered, or current traumas that are happening in the world that might be impacting you. And a trigger is a certain something that causes a negative emotional response. It could be fear, it could cause fear, it could cause sadness, it could cause panic or flashbacks, it could cause physical symptoms. And triggers are generally multisensory, light, sound, smell, touch, those types of things. It could be heat, it could be a racing heartbeat, it could be anything like that. It could be memories, thoughts, or images. It could be the feeling of fear of helplessness. So many things can be a trigger. It could be the smell of latex gloves. It could be a racing heartbeat. It could be shortness of breath. It could be the healthcare provider standing over the patient. It could be almost anything. It could be gastrointestinal distress. It could be racism, bigotry, feelings of racism or bigotry could be a trigger, and watching that happening as well. So all these things could be a trigger, and then you have triggers for death. And we don't want to forget about that as well. So triggers, it could be the date of death that happened, the anniversary of the death, special occasions, all those memories, those are triggers as well. So know that sometimes we have to play detective in this work because we don't know why someone is acting a certain way. Sometimes a person knows, hey, I'm watching the news and it's a trigger for me, so I'm not going to watch the news. I'm not going to go on social media because it's a trigger for me. But sometimes people are not even aware of what the trigger is. Next slide, please. These next two slides talk about grief and trauma. And I really want to talk about this a little bit because it's important to think about this. There's a lot of grief that resembles trauma and a lot of trauma that resembles grief, but it's really the healthcare practitioner, the mental health provider that needs to weed out, is this trauma or is this grief? What can I do to help serve this person best? And if you have understanding of these differences between grief and trauma, you might think to myself, hey, this person is having a trauma reaction. Maybe I need to work with that before we work with the grief. Or maybe you can do both simultaneously. It really depends. But a couple of that I want to highlight to you are that grief reactions stand alone, but trauma reactions often include grief reactions. People who are grieving can generally talk about what happened, but a person who's had a trauma often can't. They can't get their words out. They can't wrap their head around what has happened, so they can't really talk about it. And the anger that Barb was talking about, anger a little bit before, and how anger can be helpful, but also anger can also become destructive as well. I was working with a group of hospice professionals who've had so many deaths in their agency, and the director of psychosocial services was surprised at his anger because it was so amplified. And what's happening in this COVID era is that grief feelings are amplified, and his anger, he said, I was feeling rage. I've never felt rage before. But when he would see people without a mask, he was not just feeling anger, he was feeling rage. So I think it's important to talk about that. Next slide, please. Another is the guilt. To me, guilt is a child's magical thinking grown up. I wish this would have been, I wouldn't have done that. And guilt and regret are kind of mixed in there, and there's perceived guilt and real guilt when you're grieving. But when it's a trauma, you're thinking, it's my fault. I could have prevented this. It should have been me instead. I made my person sick. So we want to make sure we can help the person explore what these guilty feelings are. There's a typo in the third bullet there where it says dreams are about self. Well, it should say dreams are about self. And I think that the nightmares also are more with trauma people than with the grieving people. When you're grieving, you tend to dream, you hopefully dream about the deceased and they visit you in your dreams. But when you're having a traumatic reaction, often those dreams are nightmares and you're the victim. So it's important to read those things out. And again, that last bullet there where it says trauma involves grief reactions in addition to trauma reactions. Next slide, please. I want to make sure I have room for Carla at the end. So what can help? Well, Barb talked about the 7 C's, and Barb really set the stage for this whole presentation here with what trauma is and how you can help. In addition to the 7 C's, I think the best thing that we can do is bear witness, have an open heart, and listen to our fellow employees, our colleagues, our patients, our families, and just hear what they have to say and validate and normalize what they're saying, not question them about why they might be feeling that way or what's wrong with them. It's more about what happened to them. We want to offer self-compassion for ourselves and know ourselves, to try to recognize when we're being triggered and what we can do about it. There's mindfulness, breathwork, relaxation, CBD, all these different letters that I listed up there, with EMDR as a gold star for trauma work, and rituals. And we can talk on and on about rituals. And rituals are any act that are done with intention. And even though you can't have the funeral ritual right now, you can do a private ritual. My favorite ritual every morning is having a cup of coffee with my mother using one of her favorite mugs. Next slide, please. I wanted to end before I switch over to Carla with post-traumatic growth, because I think this happens as well. And this is what keeps me excited and what keeps me in the field, is seeing how people grow through their trauma and they grow through their grief. And they might have the things that you see listed here. And it doesn't happen automatically, but it happens often in the aftermath of a shattering experience, like a trauma, like the pandemic. All these things could cause changes in people, and people look back on how they were and who died and what they want to take with them from the past and bring it forward with them into the future. And we see the renewed sense of spirituality, growth in character, existential awareness, and the like. So I leave you with that. If you have any questions, so I can give time to Carla, I'm going to leave you with this, but please feel free to contact me with questions and thoughts, and I'd be happy to answer them. So Carla, I'm moving it on to you.
Thank you, Diane. So in the midst of this pandemic, the researchers have been struggling to get clear about how it is that we can best support you, frontline workers, healthcare workers. And in a recent JAMA article called Understanding and Addressing Sources of Anxiety Among Healthcare Professionals During this Pandemic, these are some of the results that were found. Instead of being a quantitative numbers-based research study, it was qualitative. They interviewed 60 some, actually more than that, employees working on the front lines, and got an idea and coded and then grouped together what the most prevalent things were that they said that they wanted from their leadership, the person, and even from their colleagues. And these were the multiple areas. I know this font is small, but as you get the slides later, you'll have access to the link to the actual article, as well as the slides so that you can see more of this. But in general, what they most want is to be heard, as Diane was sharing. They want to feel protected, prepared. We want to feel supported, and we want to feel cared for. Next, please. As we know that we are quite self-reliant, we don't tend to reach out and ask for help. We're really good at giving it. We kind of suck at taking it ourselves. And so because of that, leaders are encouraged to make certain that we really pay attention and check in with our colleagues and with those whom we're leading, because now more than ever, we need to encourage people to ask for help when they need it, but also approach them. They may not know how to ask for help. They may not know what they need and therefore be hesitant to ask. So we can approach and check in with them to find ways, practical ways, that we can be with them. I've heard of no greater leadership during this time than the leaders who tend to their own struggles, find someone else, some other grown up in the room. In my consulting and coaching work, I'm doing a lot of sitting on Zoom calls with a room full of leaders or Zoom room full of leaders as we talk about their own struggles, to get them grounded so that they then can go and be that non-anxious presence and listen to their teams, to hear what their teams are struggling with. But the number one thing that I've heard that has been most supportive is when they just pick up the phone or they send out a text and just call and check in and say, how are you doing? When there's a need to be at the bedside and people are anxious about going to the bedside and using PPE, or what procedures do we use that are safe or not. Having a leader go in with them, having a team lead, a clinical coordinator, a lead nurse go in with them and say, this is what we're going to do. We're going to walk through this and do this step by step together the first time, so that the next time when you come back to do this on your own, you'll feel confident that you know what you're doing. There is something, interpersonal neurobiology talks about the interaction between people and how that can decrease our threat arousal response system, our sympathetic nervous system with that anxiety. Easing anxiety often is just as simple as being present, being grounded, being present, and saying, we're going to walk through this together. So the more that we can do that, and also to hear them and express genuine gratitude to people for the work that they're doing, the better off they and organizations will be. Next, please. And at the end of the day, the greatest of all of the items from the research came out to be, please honor me. So that the genuine gratitude that we extend, we want to give, but we want to make certain that it doesn't ring hollow, because if we're not also hearing them, protecting them, supporting them, preparing them, caring for them, we can thank them all day long. But if they're not feeling truly cared for in these other areas, that gratitude can ring hollow. So this is not the time to end our texts and our phone calls with, and thank you for all that you do, unless we are also really, truly showing up for them in other ways. The more we do, the better off everyone will be. Next, please. As we talk about post-traumatic growth, how we're going to be on the other side of this, think about who you want to be individually, as a professional, as a team, and an organization on the other side of this, especially since we don't know when that will be. But who do you want to be? Now is the time to get preparing for and practicing that today. Resilience is when we come through a challenging time, not having just survived, but actually thriving through to the other side in that post-traumatic growth that Diane was talking about. Next, please. There's a great article that you have the link for on that last slide to the New Yorker that when you get the slides again, you'll be able to access, but it's from the New Yorker of February of 2016, I believe, on how people become resilient, to give you more information on resilience. The protective factors of resilience, there's inconsistent literature about there's not one model of resilience, but these are the 6 that most commonly come up as strong predictors of resilience in the literature. It's the perceptions and meaning making, the stories that we tell ourselves in our head. Are we telling ourselves the worst possible case scenario? Because it takes just as much energy to come up with the worst possible possibility of the future as it does to think about what the best possible option may be. And if we visualize this, we stand a much greater chance of moving in that direction. It's about internalized locus of control versus learned helplessness, focusing on what we can do rather than constantly beating our heads against the wall and grousing constantly about what we can't do. It's okay to name it and grieve it, but then we move on and say, what can I do? It's about building that connection and community and support. Social contact theory tells us we feel more safe the more close, strong, positive relationships we have, because we know that during a hard time, no matter what happens, we ultimately will not fall because our social network will catch us. Some of the greatest predictors of those who came through Vietnam War era veterans, survivors of sexual assault and other significant traumas, or all trauma being significant, but other traumas, is if they felt that they could take action on their own behalf, internalized locus of control versus learned helplessness, and if they felt like they had adequate social support. Those 2 things, if we do nothing else, and practicing mindfulness so that we can be aware of what's going on with us and what we need, monitor the stories, seek out help, we get to find a sense of calm so that we can think clearly enough to then reach out and ask for the support and be the support for others. It is about feeling safe enough to then be adaptive and flexible in our coping skills rather than getting stuck and rigid. It is about doing impeccable, exquisite self-care. A nurse practitioner I was on a call with, leading a webinar for a group of physicians and advanced practice folks, and she said, well, you mean even during a pandemic, we need to do self-care? And I said, oh, baby girl, especially during a pandemic, we must do self-care, or we'll be able to do nothing else well for the long term for ourselves or anyone else. So it's not just a good fuzzy woo idea, and it's not something we can let slide. We need to up our self-care during stressful times rather than let it go by the wayside. It is our greatest clinical competence. And it's about practicing gratitude and hope. Those aren't feelings, they are practices. I become grateful, I feel gratitude, I feel hopeful when I practice gratitude and I practice the things that build hope by taking action on my own behalf and surrounding myself by people who believe in my ability to find my way through. Next, please. As we talk about emotional intelligence for us in serving in healthcare, it is about these 4 components. The most important of them being mindfulness, how we practice in a mindful way, the things that we're already doing so that we can monitor our emotions rather than letting them run off with us, so that we can be mindful of when we're being critical of ourselves and others and instead extend empathy to ourselves, and about how we navigate the relationships in our engagement. But mindfulness, according to John Kabat-Zinn, whom some of you may know, his work is that moment-to-moment, non-judgmental awareness, paying attention on purpose in the present moment. Next, please. So these are some of the practical, tangible things that we can do. I'm going to spend a minute on this and then want to invite any other questions to see what we can answer for you. And we apologize for having so little time today, but we're trying to get a lot of information to you, and you will have the recording and access to the slides later. But pay attention to our thoughts. Befriend that crazy inner roommate that talks and says all sorts of scary, crazy, yucky, ugly, mean things to us, and monitor the inner chatter. Be impeccable with your word. Don Miguel Ruiz says that it's not just the words from the 4 agreements. It's not just the words we speak to others we need to be mindful of, but the words we speak to ourselves. Find that depth of self-energy inside of you, that wisdom inside of you that can be more calm, curious, get more clear about what you're feeling and what you need. Extend compassion to yourself. Have fun, confidence and creativity, courage, and a connectedness with yourself and others. Polyvagal theory tells us that if we inhale more quickly than we exhale, for instance, the 4-7-8 breathing, in for 4, hold for 7, out for 8. That does a much better job of decreasing, stimulating our vagus nerve and decreasing and activating our parasympathetic nervous system to decrease that hyperarousal of that stress response that we're all feeling right now. It doesn't take a lot of extra time or money. In fact, it doesn't need to take any extra time. You can do that breathing while you're sitting at a stoplight or in the bathroom. The badge ritual. If you're working by telehealth, wear your badge when you're working. And when you're not working, take it off, to keep you mindful of some sense of work-life balance for so many of us who are working from home. Same thing if you're on shift and in the field. When you come home, once you've done your due diligence and done what you need to do, put the badge down and put work down with it. Trust your on-call team, other staff members, but give yourself time away. We must. As we're hand washing already, use that as a time to lower your shoulders, to breathe, to feel your feet, to get grounded, to relax your belly where you've sucked in. When you walk through doorways, imagine a waterfall coming down through that doorway and washing all the stressors of the day off of you so far. And when you come back out of that doorway, wash the energy of that interaction, that meeting, that visit off of you so that you don't accumulate stress all day long. Mindfully engaging in the things that we are already doing can be incredibly helpful. Next slide, please. So do something. Find a plan of care. We do plan of cares for others all day long. Do a plan of care for yourself to take some action. Next slide. Review the things that you know to review that we do for patients and families all the time. And then next slide, please. Develop interventions for the things that you can do to tend to yourself. Last slide, please. We know that, as the saying goes from Haruki Murakami, is that once the storm is over, you won't remember how you made it through, how you managed to survive. You won't even be sure where the storm is really over, but one thing is certain. You come out of the storm, you won't be the same person who walked in. That's what the storm is all about. I noticed that we are right almost at time with about a minute to spare, and so I apologize for not being able to access questions at this point. But I will hand things back over to Carrie, and we will continue to reach out to us to respond as we can to your questions. As Diane and Barbara have both shared, please reach out. We'll do what we can to answer what we weren't able to answer here today. Hopefully something has been helpful, but take care of yourselves, be good to yourselves and to each other, and together we will make it through this.
Thank you so much, Carla, Barbara, and Diane. Diane, one question that's coming in, and Carla too, for that matter, managing the grief process when you're not able to have those funerals and those rituals that we're normally having. Any advice that you could share in the last minute that we have together?
Sure, it's Diane. Can you hear me?
Mhm.
So I think one of the things that you have to do is you can, I think the use of rituals is really, really helpful, that you can do a personal ritual to honor the person that died. To stay socially connected, it doesn't mean that you can't, you still can do social distancing, but you can stay socially connected with people as well. So you want to honor your grief and give yourself permission to grieve during this time. It just might look a little bit different, but to find a way that you can honor the person that died, and rituals are really helpful. And then of course, self-care. And we talked a lot about those different self-care things that you can do with mindfulness, meditation, whatever floats your boat for self-care, because each person's self-care is going to look a little bit different. Where I might like to take a hike, you might like to bake a cake. So whatever is good for your self-care, do it. But those rituals are really helpful. And I think if you can encourage your bereaved or you yourself to engage in some sort of a personal ritual, whether it's creating a shrine, lighting a candle, having a cup of coffee with your person, going to the cemetery, whatever you can do will help in the grieving process.
Thank you, Diane, and thank you all for participating in today's webinar. We are grateful for this time with you. If you're interested in receiving CE/CME credit for today's webinar, please complete the attendance evaluation and CE/CME credit form online by July 3rd. A link to the forms will be emailed to all participants within 24 hours. We have additional tools and resources related to trauma-informed end-of-life care on the NHPCO website at the link on your screen. And many thanks to Barbara for providing some additional resources that you see on the screen, and you'll get these in the slide. The recording and the slides will be posted to the NHPCO's COVID-19 webpage, along with many other resources, and we are updating that daily. Please do not hesitate to reach out to any members of the NHPCO team with questions. That concludes our webinar for today. Thank you so much for your time. Please stay safe and stay well. Have a great afternoon.